strategic transformation and improvement at BC Women's Hospital and Health Centre. Her passion is transforming healthcare systems where the voice and perspectives of patients' families, along with the talents of those who provide care, are the driving force to never stop seeking new ways to innovate and improve care. Dr. Rob Everett is the Clinical Assistant Professor, Department of Pediatrics, University of British Columbia. After completing his residency training in 1998, he joined what is now known as Fairmont Pediatrics. Dr. Everett is currently the medical lead for pediatrics and mother-baby care at BC Women's Hospital. As a consultant pediatrician, he enjoys caring for children of all ages. He has a particular interest in newborn care and care of the medically complex child. He enjoys teaching and is a regular speaker at continuing medical education conferences. Dr. Everett has been honored several times over the years with BC Children's Hospital Family-Centered Care Awards. I would like to invite Marg and Dr. Everett to the podium to introduce themselves and their partner.
Hello, everybody. Thank you so much for the invitation to come and share our story with you. It's such an honor to be here. I didn't even realize this conference was going on, so it's truly an exciting endeavor you're all taking. I just want to get an idea of how many patients are in the rooms. Okay, so we've got a couple, so hopefully this will speak to you. We're here to present a story, really, around our mother-baby care unit and our new neonatal intensive care unit, but really from the eyes and the drive of our patients. And so Lorraine did introduce. I'm Mark Seppelt. I lead a team at Women's that sort of helps drive some of the innovations and makes people think differently. Rob Everett is the medical lead of the mother-baby care unit, who really has been a champion in terms of moving this change forward and other changes. And Amanda Lockage is our mompreneur here, and she really had the honor and the great experience in terms of mother-baby care at BC Women's, and is very much passionate about this. She's seeking to produce a documentary, of which you'll see a pitch for as part of our presentation. Your mother, if you remember, she didn't just give birth to you. She raised you, and in the first minutes, days, and weeks of your life, she held you. She fed you. She nurtured you. And she nurtured your development. She understood your ins and outs. She understood your preferences from the very beginning and habits. And she kept you safe. And she raised you to be the magnificent adults that you are. But imagine if you were born premature. What that would have been like for your mother if you were forced to be separated and cared for in the hospital in a different area. Imagine what it was like for your mother when they reunited you with your baby from the NICU, not knowing where your mother didn't know you as she was going home, but she was expected that she knew you because she was a mom. And somehow, together at home, you would figure it out. The beginning starts in the womb. You are tied to your mother through the umbilicus. And then, post-birth, the umbilicus gets cut. But the umbilicus is more than just a piece of our anatomy. There's a conceptual, it's conceptualized as a psychological, biological umbilicus between mother and infant, and it's very critical to maintain the first month of life. The goal is to keep the bond together to enhance infant growth, nutrition, development, and more importantly, attachment with the mother for infant bonding and the prevention of abuse, abandonment, failure to thrive, and neglect. In the traditional NICU, we certainly do this. We separate the baby and the mother. The baby goes to, and this is actually a picture of one of the previous NICU in the bays. And you see that the baby's wrapped in technology, being cared for by highly technical people and professionals. And here's the mother separated into the postpartum area. Recent studies have confirmed that separation is the most stressful event in a woman's life. And throughout this hospital stays, it can adversely affect her relationship with the baby and the outcomes. Certainly, when you think about the negative impacts, it is very much on the baby in terms of their own physical weight gain, but it's really the psychological from the stress in terms of their well-being and brain development. Mothers certainly have shown in studies to experience depression, post-traumatic stress disorder, anxiety, and stress-related conditions. In preparing this talk, I was really surprised from how much evidence there is in the literature around the emotional and long-term impact in terms of that bond as the child grows up in the family. We at BC Women's, and I got this quote from someone, I went, really? For 85 years, before we were, we were branded as BC Women's, but really for over 85 years, our organization has been a leader for advocating for the advancing the health and well-being of women, newborn, and families. As our executive team moved forward with this, we actually created this commitment statement. And the center of the statement is something that we take very, very, very true to our hearts. Our driving principle is that we honor women's voices and values. So when you're looking at maternity care, avoiding separation really is the core principle at BC Women's Hospital. It's not only in the NICU, it's in our birthing suites. It's in our postpartum areas where there's really high-risk mothers that go with their babies and keep the babies together. It's in our first square model where we're caring for women from the downtown east side who really have struggling with substance use. It really is a tenet in our organization, and we take it very seriously. A really cool thing is we had an opportunity. Sorry, I do have to stand here, don't I? They were going to give me a mic, and I do, but I'm going to try to stand here. So you know that we built a new hospital, the TACC Acute Care Center, but really the hospital is just a building. We took this opportunity very seriously to look at how we were doing things and to advance some of our models of care. I'm going to show you a video that does feature our leaders and Amanda, so you can get a feel for our mother-baby care unit in our new NICU at BC Women's Hospital and Health Center located in the TACC.
Mothers tell us that being separated from their baby is the single most traumatic event of having a baby in the NICU. I think it compels us to try to find a way to do things better, and this was our beginning to do things better.
What they're trying to do at the TACC Acute Care Center is keep babies who need medical attention with their moms in the same room, being cared for by the same nurse at the same time, which is groundbreaking, it's revolutionary.
There's lots of medical evidence that tells us that the ability of having mom in the room drastically improves our ability and our endpoints as far as the baby's health.
Also, we need to put the support so that the care can be provided in a way that the nurses feel supported, keeping mothers and babies together, not separating them when we don't have to. When we have healthy women, we have healthy societies.
Good morning, everyone. My name is Amanda. I am a mom and a filmmaker and a mompreneur and a patient partner. And the baby in the video with the feeding tube was my son Elijah, and this is him in a trip to Tofino a week ago. So I'm going to tell you briefly about how Elijah and I came to be cared for at BC Women's NICU and our experience there. So when I was single and in my 20s, I flippantly said, I give myself until I'm 44 to have a baby. I only met my husband at 38, and we spent 2 years dating long distance while I was in Toronto pursuing doctoral research and he was here working. And it was another year until we got married. And so 6 years after meeting him, after multiple losses through an IVF process, and after spending our entire life savings, my husband and I got Eli. He unexpectedly came 6 weeks early. He was at 33 and 6, so he came literally the day before my 44th birthday. He's January 23rd, I'm January 24th. Careful what you wish for, right? And while this was the best birthday present my husband could have given me, it was also one that was really fraught with fear and stress. Had Eli come on my birthday at 34 weeks, there were certain protocols that he wouldn't have been eligible for. So while I was in labor, I was listening to the doctor on call and the intern discuss whether or not to give Eli these medical interventions, things for brain bleeds and stimulating the lungs, because if he had come a day later, he wouldn't have had them. I've always been a really great advocate for my own health, so I piped up and said, if I have any say in the matter, I want any and all interventions that you think can help my baby. So I then had all these bags of fluid hung on my IV. But the result of that was that even before my baby was born, I felt that my voice in his care was taken seriously and listened to by the medical professionals. They allowed me to be part of my baby's primary care team. Shortly after he was born and there were no breathing issues, he was taken to the intermediate nursery because I had gestational diabetes, his blood sugars were wonky, and he had jaundice, and they needed to keep his little 5-pound, 2-ounce body nice and warm and safe. And my husband and I were told to go off and get some rest. So that first night of my son's life, I was in the postpartum ward with all of these other moms in their private rooms with their babies, and I was alone with my husband, which was a very different experience. Hours after my son's birth, we weren't able to hold him. The next morning, I went back to the nursery, and again, luckily, we were in the intermediate nursery. There were about 10 beds where there's the incubator and the chair and little else, and I sat there all day holding him. And while I was there, I thought, I was trying to breastfeed. There were all these other moms in there trying to do the same thing. And I thought, I'm not sure how long this is going to last. But I can't imagine for some parents who are there for months and months on end in this sort of big room doing the same thing, not being able to focus entirely on your little one because there's all this other stuff happening around you. I had a friend who was in the general NICU for 3 months with her daughter, and that room had 60 beds and incubators, all going at the same time, often. So one of the intermediate nursery nurses mentioned to me that there was this pilot program happening in the general NICU while I was there, luckily, where they were retraining NICU nurses in postpartum care to make them ready for the new hospital that was coming. And so I spent all day trying to find out how I could get into this mom-baby unit, is what they were called. And by the end of that night, I was told there's no chance because they were taking moms and babies straight from delivery. So after being with Eli for the whole day, I had to put him back in his incubator, and I had to go to my room in another part of the hospital. In the middle of that night, though, we were woken up and told that a mom who had been taken there took one look at this windowless, airless, weird bathroom situation. It was kind of a weird semi-private room. A converted on-call room, and she looked and said, "There's no way I can be here." And so because I'd been so vocal about wanting to be there, they said, we'll take you. And at the time, there were 2 of these mom-baby units in Canada, in all of North America, where the mom and the baby are cared for postpartum in the same room by the same nurse. That's the catch right there. Like I said, the room was a converted on-call room, so there was a hospital bed for me, a incubator for Eli, and then usual emergency equipment and a milk storage fridge. My husband was sleeping on this really thin, uncomfortable pull-out mattress thing until I persuaded him to go home and get some sleep. And although, again, this was windowless and airless and weird bathroom, I felt like I had won the lottery. Getting to stay in the NICU with my son, where I could safely leave some belongings, I could go out and stretch my legs. There was a nurse stationed outside our door 24 hours a day. I learned how to bathe him and feed him, how to watch him, not the monitors, how to feed him with his NG tube, how to remove that NG tube. And all of this was invaluable. I got this crash course in learning how to care for my new infant from the best people in the world at looking after new infants. And not only that, I felt that I was really supported by them in learning about my son, but I felt that my health was really important to them too. And I think sometimes in NICUs, the mother gets overlooked for the baby. I was discharged after 2 days, but I got to stay in this private room as my son's companion. And I kept thinking about how if we had been in the general NICU, every day I would have had to get myself to the hospital. I would have had to probably pay for an entire day's worth of parking. I would have had this one chair where I couldn't safely leave anything. I would have had to go get my own food, and I would have had to repeat the process for who knows how long. And I would have been in this room, open room, with all of these other moms and their stories playing out. So in these 10 days, because I was flying on hormones and I was going a little bit stir crazy, I talked to every nurse that came through, asking them, what do you think about this new redesign and implementation program that you're going through? And every single one said, this is going to be better care for mom and for babe, bar none. That doesn't mean they were all necessarily on board. And the kind of a little bit of the pushback that I heard of this isn't what I signed up for. I want to take care of babies. I didn't want to take care of mom. Really intrigued me because that attitude, coupled with the fact that the new Tech Acute Care Center was being built, and in that unit there were going to be these mom-baby units, there was a lot of tensions that the hospital, the administration was going to have to deal with, and that I find that fascinating. So it started me down this path of making a documentary. And as I put together my team of it turned out to be all female producers, writers, editors, it was shocking to me that the majority of them had issues regarding infertility, or, other birth kinds of stories, similar losses, or needing NICU care for their babies. My story is not unique, but there is so little out there about these kinds of experiences. And since then, the documentary's grown to include other services that we were lucky enough to receive, like the milk bank, and identifying ways in which the hospital is going to handle new NICU care for moms with addiction, for moms with mental health issues. And as we've been promoting and looking for funding, there are so many stories that have come up. People that are either total strangers are telling me their stories, or people that I've known for decades that I had no idea that their child was even in the NICU. Because, again, nobody talks about it. And if you're not in that struggle, people aren't very forthcoming. So with this new NICU in the Tech Acute Care Center and its 12 designated mom and baby units, the flexibility of the rest of the NICU to have moms and families stay there overnight all the time. BC Women's is really at the forefront of neonatal care, and we're really lucky to have this kind of care in Canada, and leaders like Dr. Everett, they're pushing for the best possible outcomes for moms and baby, with windows, spacious rooms, private rooms, pull-out couches. Moms aren't going to want to leave this NICU. Thanks.
So those of you that know me in this room know that if I sit there behind the podium, I become really restrictive, so I just have to use the mic. I used to. So really an interesting experience. I'm just going to give you my experience because I was very heavily involved in the design of the NICU. We used a lean methodology called integrated facilities design. And I'm going to just give you some of my observations around how we experienced involving mothers in this design. So it looks really basic. It's like we were trying to sort of just stack the building, but then start drafting what a room would look like. And you can see we use Lego. And we had the baby in the room, and any of you have done any flows, every different string is a different provider flow or a lab flow or a family flow. So we were trying to figure out what this would look like and how big of a room we needed. There was a mother, Hillary, and I will never forget this. We were in the basement of WHRI on campus, and she kept on taking the Lego and putting it back in the room. And I was just observing the team, and the team kept on taking the Lego out and just trying to sort of figure out where the equipment was going to go. And she kept on taking the Lego and putting it back, silently. And she's basically saying, I want to be there. Like, figure out where I'm going to be, not just my baby. So that was sort of the beginning of this. We definitely involved families. During this integrated facilities design, we actually went to a Safeway out in New West and fully mocked up the NICU. That's what you're seeing here. Spent hours and hours in the room with our architects when we were designing the concept, and certainly mocking up full rooms, etc. We had about 8 mothers in the room when we were designing the original concept, and it was interesting. We had created an environment where there was 30 moms on Twitter. I didn't actually even realize we had done this, because every time we needed to make a decision, one of our moms would go, okay, I just got to vote. 20 out of 30 say yes. I mean, they were literally live in their homes, like having coffee, waiting to vote on yes or no about what we were doing. Meanwhile, we're starting to learn, and mainly it was our leaders of the NICU, that there were things going on in other areas. So in Estonia, I think it was 1979, there was a small unit, and they were having a nursing shortage. And the neonatologist said, you gotta stay with your baby. Like, we need help. Like, we don't have nurses. So then moms started to stay with the baby. And they saw these outcomes. 37% weight gain, fewer infections because there were less providers touching the baby, decreased need for antibiotics IV, improved social and psychological development. Then they started seeing benefits for the mother. Just a more highly engaged, rapid recovery from childbirth, increased confidence and ability to mother, and strong attachment. And it was Dr. Levick, I believe, who said, all NICU should consider doing this. But it was really by circumstance of having a nursing shortage. Then, as you know, in our way that we design buildings, so we got this concept going, and then the architects, we bid for architects, or the architect that built the TACC got the bid, but we just kind of handed off what we had conceptualized. So they took it, and you probably were involved in this if you're site redevelopment in Fraser Health. They start getting you on that detailed design, and that's what you start seeing, right? You're in day-long meetings. It's insane. As we were designing the NICU, it was fascinating because it truly felt like we were building the airplane while flying it. There was a concept that we put in the principle when we were doing integrated facilities design, our original design. We are building tents, not castle. What that means is we don't know what the model of care is going to be in the future. We have to create the space so that we can have some flexibility. I'll never forget sitting with the architects and our NICU team saying, yeah, we need bathrooms. You can see they're here. We only got 6 rooms with bathrooms. And they're going, well, that wasn't with the original contract. Yeah, we need washrooms. Because originally it was like, yes, we are building TACC to give you 10 more NICU rooms. But, parents, common parent rooms, they can share bathrooms. What do they need a bathroom in the room? The babies doesn't need a bathroom. So the NICU wasn't originally contracted to have bathrooms. And we're saying, no, we need washrooms. And then I'll never forget the conversation. We need 3 head walls. And they're like, huh? Why? We're like, well, we may want to put a mom. And they're like, oh, no. Standards, all this. There's no way a mom's on bed fits in this room. So we ran down, and I think this was sort of what it looked like, to Shaughnessy Auditorium, mocked up the whole thing, taped it all down, brought all the equipment in, walked around, did all of our flows. Yep, we got enough room. We basically told them, put 3 head walls in. So we actually then ended up with rooms that in the mother-baby care model, if mom had twins. Not all of them, but we have at least some capability. It was just an amazing experience for me. You got your architects, you got your contracts, but here's the model that we're learning, and here's the mothers telling us, absolutely, we want this. So that's the room Amanda was talking about. I'm not going to go into detail. The nice thing that we did was we had funding. So we took our on-call rooms in the original NICU and actually created 2 rooms. Shared bathroom, but 2 small rooms. They were tiny. Had air, Amanda. But it wasn't ideal. But what we needed to do is started to test the model and go through continuous improvement until we got it right. It was interesting. I really liked this time that we did because we actually did patient experience surveys across our NICU. The same survey went to the 2 rooms, the traditional intermediate nursery model, and then the NICU. And we could cross-compare what patients said and families. And the biggest thing I remember hearing is the biggest opportunity for improvement of this area was, could you give me a private bathroom? Could we give you more room, more space? Well, the main NICU, the biggest opportunity for improvement was when I come in here, I don't know where I'm staying. I don't know what my role is. I don't know what to do. Should I touch? Shouldn't I? Am I supposed to be there? Am I not? So it was interesting. We also prepared the entire NICU for the concept that you are now going to have the family in the room. So the entire TACC was actually built on this principle of core care team, and that is the parent or the patient, the most responsible provider, physician provider, and the nurse were the core care team, setting the concept of you set the plan for the day at the beginning of the day and you reconcile it at the end, that they're equal partners in the care. And so we did start creating some opportunities here where we recognize, and we're still working on, how do you actually involve the mother in the room? It's not just her space, it's the family. How do we involve them in the care? And this takes work. Rob will share the physician perspective here.
Yeah. You guys can hear? Thanks for inviting me. My wife actually works as a child life specialist at Surrey Memorial Hospital, so I get to hear on a regular basis the great things that you do, which encompass family-centered care. My role is at Women's Hospital, and my task today is to go through, again, the physician perspective of some of the changes that have gone on, take you through a bit of a tour of what it actually looks like, let you know how we're doing, and give you a sense as to how we nudge physicians along for change, because I'm not shocking a lot of you by saying sometimes that's the most difficult part of all of this. How many docs in the audience, by the way? 2 of us. So yeah, I like this cartoon. And I knew I was speaking at a conference which was talking about patient experience, and unfortunately, this is the experience that a lot of us have with our doctors. We're kind of separate from the mighty doctor, and so it's a pleasure to be here, and hopefully, I can represent the profession well. So, how does mom and a baby get to the mom and baby unit? Well, it's the actual unit from a medical perspective is essentially a little 2 units. So, babies who are 33 weeks and above needing mild respiratory support, IV therapy, and so on. That's ultimately, from a baby perspective, who ends up in there. But the journey usually starts in our urgent care center, which is essentially our assessment room. It's important to realize that most of the babies that end up in this unit or other level 2 units, it's unexpected. It's either an event which has happened unexpectedly after the baby is born, even if they're term, or it's that a mom has gone into preterm labor unexpectedly. And so I think that's important when we're talking about the experience of the mother, is that this wasn't the plan usually to end up with us. And I think one has to look with that lens when you're taking care of these patients. This is what I walk into every day when I come into work. I always find this a bit humorous because this huge photo of this mother heading into the urgent care center, it looks like she's read a recent hand hygiene report and she's carting in the hand hygiene cart with her. This, like many other maternity centers, this is a typical labor and delivery room. This is our single room maternity care unit, so very similar to what other people would have. So women would generally come up to from the urgent care center after assessment by their physician and come to deliver here, or in one of the newer labor and delivery units in the acute care center, which tends to focus on the high risk pregnancies. And then this is one of the rooms from the new unit. And so after the baby is delivered, we attempt to, as much as we can, keep mom and baby together if there's no immediate medical issues, and ultimately move them together into this room where, as the others have said, we have a designated nurse, a NICU nurse, who is responsible for the nursing care of both the mother and the baby. So you can see the incubator, there's the bed, and you can kind of see the couch behind the bed, which is where Dad would sleep. And what Amanda would really appreciate is you can kind of see the sliver of actual natural sunlight which peeks into these rooms, which was not her experience with the rooms that she had in our old NICU. So this just is a bit of a video describing or showing the patient experience. This shows a mother who has her ID bracelet on, so she's being cared for by the NICU nurse. The door behind her is the door to the bathroom, I believe, and we have the ability for Dad to stay with the family, and you see Dad there is participating in the skin-to-skin care of the infant, and everyone is happy and blissful. Well, I don't know about that. It's interesting. I started my position as the medical lead of the mother-baby unit about 6 months before we moved in there. So that was fun. And it was a big deal, obviously, when we moved in. We had, at Children's and Women's, over 100 patients being transferred to the new building on one Sunday. And the following couple of days, we had our first admissions to the mother-baby unit. And I remember going by the family that was either the first or the second. They were a set of twins. And I walked by as the medical lead to kind of see how things were going. And I peered in the window. And it was one of those moments that was really quite profound for me. Looking through that window, I saw the twins, I saw the mother, the father, there was the sibling. Everyone was relaxed. It looked like I was looking into their living room, despite the fact that the babies were receiving level 2 care. And that's when I realized this kind of what it's all about, is to provide the care that you need with the least stress possible. And as we've talked about, keeping the family together, not just the mother and the baby, but the father and the sibling and everybody. So it was that I realized all this work that they had done leading up to it before I came along was really going to make a difference. So as Marg has implied, there's lots of evidence to suggest that this is a good thing to do. It doesn't just feel good, but it actually makes a difference as far as our ability to care for the families, including these endpoints. So, I mean, there's psychological endpoints, but there's physiological endpoints as well. Improved breastfeeding, not only on discharge, but after people go home. Reduced length of stay. That perks up the ears of administrators. And improved family experience when you actually ask them. So, how are we doing? Well, I think we're doing pretty well. Our data is somewhat limited. We're a year into this, but we have been able to extract some data as to how things have changed over time. Basically, if you look at this, the blue are mother and babies who are admitted together, and the red are where the baby's admitted without the mother. And most of those have been because we had exclusionary criteria for some of the mothers based on their medical status. So if they were at a high risk of a postpartum hemorrhage or had complex medical needs, that because we had NICU nurses caring for adults for the first time in a number of times, those were exclusionary criteria for those moms. So those that we could admit together, at least based on those criteria, you can see that our ability to get breastfeeding going more quickly seems to have improved. It's improved generally, because I think we're paying more attention to it anyways. But what this shows us is if you keep the mom and baby together, they actually get to breastfeed better. Well, that's not really shocking, but it's nice to see the numbers, I suppose. What about breastfeeding in general? Not just the first feed, but breastfeeding in general. Again, we found that if you keep moms and babies together, so that's the blue line there, that our success with breastfeeding improves. Again, intuitively that makes sense. Important to just make sure that that's what's actually happening. What about mom and mom's length of stay? Has this made a difference to that? Well, it appears to. Over time, the maternal length of stay seems to have decreased a little bit. But again, what it seems to show, if you compare the blue and the red, that we actually seem to have decreased how long mom is staying with this model. And I'm not totally sure why that is. I have some ideas, but of course that's the kind of thing which people appreciate to see if you're reducing length of stay. And what about the patient experience? What's their experience been? And how often do the moms feel that they're actually part of the team and they're participating in the care of the baby? What this does is the mother-baby is our new unit. IN refers to our old level 2 nursery where we didn't have the capability of doing this. And in short, you can see the green is a lot bigger, which means that moms feel more empowered, that they have been able to participate in the care of the baby. Again, that sounds like it should be fairly straightforward and obvious, but important to see that this model seems to increase that perception. Okay, you might have seen this cartoon before. So I started my job as the medical lead of the mother-baby unit. Again, it was a couple of years ago. And for the year or so prior to that, I was the pediatric representative for our baby-friendly initiative, which was really focused on getting reaccredited with BFI for our hospital. And my challenge in that, again, relates to our unit in that it all relates to trying to keep mothers and babies together around the time of delivery. Our task was increasing direct skin-to-skin contact for the baby and mom after delivery, because we weren't very good at this. And as we were going towards baby-friendly initiative, we found out we weren't very good for it. So I was a physician who kind of had to sort through this. Many of you in this room know that there's lots of benefits to, rather than plucking the baby from the mother, a perfectly well baby from the mother, after delivery, keeping the baby together with the mom. The baby does better. There's transitional changes which are much easier as the baby goes from intrauterine life to extrauterine life. They're better at maintaining their temperature, their blood sugars. The breastfeeding rates increase for sure. There's less crying. It's funny, as we've transitioned more and more to doing what is right here, I often get concerned because we'll have a baby with the mom and the baby's quiet because they're happy, and everyone gets concerned. It's like, why isn't the baby crying? It's like, because they don't cry if you actually put them with the mother. They cry when we take them. So, yeah. And other things like decreased pain response and improved parental bonding. So this was the old days, as Mark had mentioned. We had all this equipment, both really old equipment and in the standard NICUs. And really what this stuff was doing to some degree was just replicating what Mother Nature has given us already. And so that's the lens that one kind of has to look at this. So what was the problem? You know, we looked at our rates and we didn't have great rates of babies spending an hour skin to skin with the mom after delivery. And you know, the truth of the matter is it seemed to be the pediatricians that were the problem. I thought everyone liked the pediatricians, you know, they're nice and, you know, they're friendly and the kids like them and everyone's happy. But it turns out that we were the red apple that was obstructing this. And there was a couple of reasons why that was the case. So in our institution, we have about 7,000 deliveries a year, and the pediatrician who's there, they're busy. They're attending a lot of deliveries, much like Surrey as well. The pediatricians are very busy at Surrey, I know that. So when we presented to the pediatricians, you know, you're going to have to let the mom be with the baby for an hour, even if the baby's well. And these were the typical responses that you would get from most physicians, right? Well, I'm busy. You don't understand how busy I am. I'm really, really busy. This only takes a minute. And then, of course, there were the others, and these were the ones, if we're talking about managing physician change, those that would think, I actually agree with what we're doing, but I'm not sure I know how to accomplish it or to speak up. So, how did we kind of change this? Well, there was a number of different ways that we changed it. You know, in the old system, the pediatrician would be called to a lot of low-risk deliveries. That's not the case in a lot of institutions. It was for us. And that was a real culture change from the pediatricians to say, you know what? You don't need to go to deliveries where everything is fine. And the institution was very supportive with that by increasing the nursing support around delivery. So that was a big one. And we were able to go and assess the babies after they'd completed their hour of skin-to-skin and the first feed. One other thing that we did is we changed the pediatric call schedules. This was a big change. We used to do 24-hour call, and there was a bit of resistance, believe it or not, to changing this. So we split the shifts so that the pediatrician was only there a maximum of 12 hours. And that actually made a significant difference. Because I think it's human nature. If you're into hour 18 of 24, the kind of the default is, I just need to get things done and I need to do this. And changing the shift actually made a big change as well. We also had some other things that the new hospital allowed us to do, particularly in the operating room. Completing an hour of skin to skin in the operating room after a cesarean section is a challenge. There's lots of logistic challenges about that, and I think we've done a lot in our institution to improve that. The standard now is every baby who's born by a cesarean section, unless they're medically unstable, will go and spend time skin to skin with the mother immediately after delivery. If the baby needs to be removed from that situation, sometimes because mom is medically unstable or the baby's unstable, the new unit actually has cameras which allows the mother to at least maintain visual contact with the baby as well, which has improved things. And I have a little example of that as well. So this mother had a medical complication, so we had moved the baby over at the request of the anesthetist. And what you can see here is that she's still able to see what we're doing with the baby on the video screen, even though she can't visually see the baby. So that's actually made a real difference. If separation needs to take place from a medical perspective, there's still that link. And I can tell you, it's a really satisfying part of my job, because I'll often watch what mom's face looks like when she's seeing the baby on the screen. And it's not like the face when she's got her baby next to her skin, but it's similar. It's similar. So that's another little thing which the institution has done, which has allowed us to improve things. So, leading physician change. I mean, you could spend 3 days just figuring this out, right? But how do I think it worked with us? Well, the first thing was, as a leader, coming on as a new leader, I had to kind of look at myself. I mean, I'll be honest, a few years before, I might have been too busy. Don't you know how busy I am? But actually working through with a multidisciplinary team, getting their feedback, realizing, you know what? I'm the red apple, made it a lot easier to communicate that all of us as the pediatric team were the red apples. And that was important. And what I was referencing before is we had a number of new pediatricians who were actually young mothers. And recruiting them, because they got it, right? Like the old guys didn't really get it. They got it. And that was a real impetus, I think, for pushing change in general.
So it does take a lot of courage to release the familiar and seemingly embrace the new. I love this diagram. So if you think that we've gotten fully there, we haven't. You know, continuous improvement is forever, and definitely the change is hard. It's not just the pediatricians, it's hard for nurses. We're continuing to work on it. So if you think about where we are in this journey, like the rooms are ready, but we're kind of on that rock still, and we're moving forward. What keeps us going is our families. I mean, it's unequivocal when we hear the voices of the families that are experiencing the new NICU, that they just are driving this. This continues to be the voices from them, continues to be the driver for keeping us going. And really, the impetus for change and realization from all of our staff and our professionals to really rethink things. It also helps when we get young mothers as pediatricians and physicians, and nurses too. We also had a really great experience during design where we brought in Dr. Ewald from Sweden. He created one of these units in Sweden. And I remember at the end of his talk, and it was just an amazing talk. I mean, I'll never forget, he showed a video of a mother. She was a beautiful young woman, and she had her baby skin to skin. This wasn't the intermediate level 2 level. This would have been a level 3 baby. And he said, look at her. And he says, the thing that she said to us is, everything's going great, but could you turn off your alarms? And he's going, huh? He goes, you know why? What I need and my baby need is sleep. And every time I actually feel the desat happening and adjust the equipment, and then your alarm goes off. So I actually can feel that the baby needs something. So could you just turn your alarms off so we can sleep? It's just again, simple but interesting concept to think about. I actually personally asked Ewald, Dr. Ewald, at the end of his talk, I said, what would you have done differently? Because it was such an inspirational talk. He goes, and he was just this guy, he felt like he came from IKEA, the Swedish. And he said, I bought these really fancy sofas thinking it's going to make the room look nice, etc. And what I would have probably done is bought family beds and not put sofas in at all. He said, a chair sends the message that you're a visitor. A bed sends the message that this is your family's room. And that was the feedback from his families. And then I just asked him at the end, what's one piece of advice for us? As I knew we were heading into those meetings with those architects. He says, listen to the voices of your patients. They will guide you. And there's no question, for me, that commitment of we honor the voices of women and their values, and it guides us. Honor means action. And so the tech really is still it's beautiful, but it's still just as bricks and mortar. And we have built a tent, not a castle. We don't know where models of care are going to happen. We don't know where we're going to be in 20 and 30 years. It's us that needs to be flexible, and we need to involve our patients and families to continuously tell us how. So the paradigm shift that we are creating and continue to work on to provide a more humanistic approach to neonatal care, taking the medical approach kind of as a back seat and putting that humanistic approach into it, could not have been possible without Amanda and many, many women and us as leaders to walk the talk and honor the values and the voices and values of women and their families as a core principle at BC Women's. And that's basically it. So any questions? And this is one of our families. I love this one with the dad skin to skin with the twins. So cute. Thank you so much for the opportunity to share our story with you. And I think we've got just a few minutes for questions.
I just wanted to say how much I appreciate your presentation. I found it really inspiring, and as we move forward with some of our new builds in Fraser Health, I think it's really going to help guide us on how to bring the patient voice into the, or family voice, into creating the new models of care. So we do have a few minutes for questions, and I have to tell you, I'm dying to throw one of these blue boxes. So, we have these special boxes that, so, any questions? Okay. I'm going to get close.
Okay. I was really inspired by the use of technology and constantly trying to keep moms in visual approximation to their infants. And it seems very simple. It probably isn't to set up and everything, but it seems very simple but super effective. I was wondering, maybe this is just too detailed of a question, but it went right to my head. How do you manage that when, say, a neonate needs a resuscitation? And how do you incorporate the patient when they're so close on the video screen like that?
Thank you for the question. You're right, that part's complicated. I wasn't involved in decisions about when the cameras went in. My understanding is the reason they're just in the operating rooms, they're not in the regular labor and delivery rooms, is for that. It's for the ability for parents to watch a resuscitation. And that comes from literature that we know, particularly from the emergency room, where parents are able to recover from the trauma of having a child be resuscitated if they're able to watch. And so that was in large part why they were put in. It's been a complicated matter, and we're not quite there, I'll be honest, with the issue of resuscitation. Not because I think it's not the right thing to do, and we have some anecdotal feedback from our institution that it is the right thing to do. It's caregivers, feeling comfortable being videotaped, in addition to liability issues. But that's the way it's going. You know, in addition to patient experience, it also relates to training and quality improvement. So you can watch resuscitations and see, well, what could we do better next time? So they were installed. It wasn't really sorted out ahead of time as to what to do. We use them for what is a more pleasant experience when the baby needs to be separated and mom's not able to be separated with the baby. But I think that's coming, and there's good evidence that's going to improve patient experience in obviously a very difficult.
So I can offer just a build on that, just briefly. So when we purposely put the delivery suite in the TACC so that proximity to NICU. There was actually an intent there because of keeping the flow together. So we're working on a huge improvement initiative come this February, I believe it is, the golden hour. So that whole sense of resuscitating in the room and adhering to standards of golden hour. And so we are moving towards the golden hour will occur in the delivery suite, in the TACC, or will occur in the OR. And they will figure that out. I mean, there's no question, and that's the team between the NICU and the maternity team. We are going to be resuscitating in the room. It's around what are we going to do from the perspective of involvement of families in this. And so we will involve a family or two in that, call it improvement initiative to see where we land with this. But in obstetrics, managing risk is important as well. But Learning and improving can never leave us as providers. And I've also heard out east, they're putting black boxes in their ORs, kind of like on the plane, to really listen and learn from what went up or down in terms of some of the surgeries when they get a CPSER or a PSLS at level 4, just to understand and learn. We have to be brave to do this. We have to learn from how we can do things better always, but this is about the mother. You saw her face as she was looking up. The baby was removed because she needed something to be cared for. There was a medical reason. But look at the calmness of her face when she was eating. Anyway. You're welcome.
I think we have time for one more question.
This is going to be a really short question. Congratulations on your work. This is just amazing concept. Do you have mums and babes where the baby is really critically ill and unstable? Like, do you have the mums in those rooms, or is it just the lower level NICU babies?
Level 2, yeah. The level 3 nursery, which would include the more critically ill, the less than 32 weeks ventilated, they, much like I think other institutions, they have a single room, which looks very similar to that room. The difference would be primarily, well, two things. One is the bathroom, which we've heard a lot about, and also those moms would have a room on postpartum or be discharged. So there's not quite the same setup for comfort for the mother in our level 3. So this model is our level 2 nursery, at least at this stage.
Regardless, we've built a tent, not a castle. So who knows where we're going to go in the future.
Okay, I'd really like to thank you for coming. I think I've found some really great nuggets of information, and I'm sure we'll be chatting with you as things go forward. So thank you again, and another round of applause. Okay, so it's now my job to move everybody along to the next places. So at 9:35, the concurrent session, C, starts, and then at 10:35 to 11:20, there's the conference walkabouts.